So please, Julia. Good afternoon, everyone, and thank you, Rosa, for introducing SeValid project. I'm really excited today because I'm realizing now that it's the first time I talk about SeValid since it started a year ago. First time outside the research team. So my name is G.Hyeraci. I'm a pharmacist by training and a pharmacoepidemiology consultant in Ars Toscana. And this is the agenda for my presentation. I would like, first of all, to give you an overview of SeValid project. That's a quite complex project because it involves many tasks, many activities, and I would say that SeValid would not exist if there were no other people that help to realize this project, because we rely on the precious collaboration of two Back4You task forces. I mean, validation task force in the person of Amira Sadegan, that's here today, and also the code list task forces represented by Sima Mohammadi and Alejandro Arana. And we also rely on the precious collaboration of the University of Florence in the person of Professor Virgili and his research team, and also 3 informatic engineers. But my presentation, I won't spoil nothing about the reason behind the inclusion of informatic engineers in SeValid. So this is the agenda for my presentation. As I mentioned before, I would like to give you an overview of SeValid project, but please consider that the core of my presentation will be the second and the third point of the agenda, then some lessons learned from this experience, and few considerations for Xabi, Ercilia, and Robert at the end of the presentation. So, what's SeValid? It's a methodological study whose aim is to estimate the validity in terms of positive predicted value, specificity, and sensitivity of algorithms used to identify cases of myocarditis and deep vein thrombosis used as case study, using the free text reported in the hospital discharge forms. These hospital discharge forms have been retrieved from the biggest hospital in Tuscany, that's close to here, and that is Careggi Hospital. But which algorithm? A specific algorithm that's commonly used in population-based study to identify the event of interest, that's based on diagnostic codes, ICD-9 diagnostic codes that are closely related to the event of interest, and the screening algorithm, or a possible a broad algorithm, that's based on diagnostic codes that might conceal cases of the event of interest, because it's not strictly related to the event of interest, but may hide some cases for the event of interest, and whose aim is to capture all or nearly all cases, or at least few additional cases that we might miss with a specific algorithm. The objective of SeValid project is to estimate the sensitivity of a narrow algorithm using possible algorithm as screening algorithm, and to, at the end of the day, apply the formulas that Giorgio mentioned in his presentation. So you understand the importance of the definition of the possible algorithm. Which are the implications if this methodology is proven feasible? SeValid project may allow the systematic estimation of real-world event incident rate, improve the responsiveness of regulatory authorities into the definition of the benefit-risk profile of vaccines, and also to improve the robustness of real-world clinical evidence in decision making. So you understand that it's crucial to develop the possible algorithm, and in particular, the list of codes to be included into the possible algorithm. Why cannot we assume that the narrow algorithm is enough to identify the cases for an event of interest? This is the example that already Giorgio mentioned in his presentation. This is the poster that we presented a few years ago at an EP conference, reporting the same results that George already mentioned. And I would like just to underline that this example demonstrates the reason why we cannot assume that the narrow algorithm is enough to identify the cases for our event of interest. I mean, this is an extreme example because I mean, angioedema could be considered an hypersensitivity reaction, but demonstrate that we need to do more when we define the algorithm to identify a key variable or an outcome in our study. But please pause temporarily the consideration I've done until now, because I would like to show you the main results we already obtained in SeValid by using the myocarditis specific algorithm, what I just mentioned as narrow algorithm. With the list of ICD-9 codes that is reported on the right, we retrieved from the hospital discharge records of G.Hyeraci Hospital a total of 38 cases of myocarditis in the period between 1st July 2022 and 30 June 2024. And the human abstractor filled out 38 questionnaires to extract the level of certainty per each case, according to criteria that are already used in the context of back-for-you studies. And these 38 questionnaires resulted in 37 cases of myocarditis with different level of certainties, ranging from definite case of myocarditis to possible cases of myocarditis, and just one not accessible case due to insufficient information to meet the case definition. Okay, so let's go to the core of my presentation. That's the SeValid contribution, a broader approach to identifying additional cases. Based on the context I just mentioned, strict coding criteria may not capture all relevant cases for the event we are looking for due to administrative reasons, clinical reasons, lack of sufficient clinical information at the time of the coding when the patient is discharged from the hospital. So what do we need? We need a different perspective. We need to adopt the coder's viewpoint to better capture relevant cases. We thought about, I would say, a qualitative tool that are interviews addressed to professionals with experience in the recording of diagnosis into hospital discharge records at the time of patient discharge. And our methodology consists of I summarize the methodology into 5 steps. So the development of the interview, the testing of the interview with expert, and the implementation of the interview based on the feedback received, the administration of the interview to relevant professional, the collection of the results, and the integration of the relevant information into the definition of possible diagnostic code list. And since this methodology has been already applied to a case study, I would like to show you what was done for the myocarditis and which are the insights we retrieved from the interview. These are the main section of the interview. The first part regards the collection of demographic information because we thought that it was important to define the profile of the person we are interviewing. So this part contains questions about the medical profession, the years of experience, the setting in which he or she works. The second part contains questions regarding the usual practice of coding cases of myocarditis. So the experience with myocarditis diagnosis, the accuracy, the completeness of the coding system that's in place in the hospital where the physician we interviewed works. And the part three, that's the most important for us, the most interesting for us because it helped us to identify additional codes that can conceal cases of myocarditis, is part three, named other codes, which contains questions aimed at capturing alternative coding choices and reasons behind them to use coding that do not contain the word myocarditis, but can hide cases, true cases of myocarditis. And here, the key insight we retrieved from the interview, in particular, we interviewed a cardiologist working in a big hospital of Tuscany with 10 years of experience working in inpatient setting, who is the responsible person to fill out hospital discharge records and who takes care of patients that are hospitalized in the cardiac intensive care unit. So she's familiar with myocarditis cases. The key insight we retrieved from the interview about the second part are also interesting because the physician confirmed us that the codes we used to retrieve narrow cases of myocarditis that I showed you in one of the first slides were right because myocarditis is a rare event, but it's usually coded correctly at discharge using codes containing the word myocarditis. And some errors could stem just from incomplete available information at the time of discharge. Another important information we retrieved from the interview is that even if the etiology of the myocarditis is known, the habits of that hospital is to use myocarditis general codes. I mean, acute myocarditis unspecified, and something similar. And now part three, other codes. That's the most important for us because we realize there are many reasons for choosing alternative codes at the time of discharge of a patient. First of all, more severe conditions or some cost consideration could lead the physician to choose another code different from that containing the word myocarditis. And the clinical condition, the pathological condition that can conceal cases of myocarditis are cardiogenic shock, acute heart failure, and intermediate coronary syndrome. Another important insight we retrieved is that reviewing 500 or 200 cases of unspecified codes, of possible codes, would likely reveal myocarditis cases. And that's really important because it's important for us to define the sample of cases we have to validate to have Giorgio's formula to work. And this is just for your curiosity that the list of possible codes, the potential additional codes for detecting cases of myocarditis. And some lesson learned from this experience. First of all, we should look beyond what we expect because focusing only on narrow cases is not enough. We should, take off the researcher clothes and think like a coder, because coders don't always use the expected exact code for a diagnosis. And also the power of collaboration, because an approach based on many different professionals help us to avoid incorrect assumption and ensures a more accurate study design. Before closing, some consideration, first of all, for Shabi. I think it's important to engage with those responsible for coding key outcomes and variables to gain useful insight from the real-world clinical practice. And also, during the development of a protocol, it's important to develop screening algorithms able of identifying additional cases for the event of interest. And just few questions for Cecilia and Robert. How can we adopt the perspective of coders to improve the identification of key variables and outcomes in the healthcare administrative data we usually we use in our study? And do you think that there are any other tools other than interviews that can be used for this purpose? Thank you for your attention. That's it from my side.
Thank you very much, Julia.